Recording in progress.
Assalamu alaikum. Assalamu alaikum wa rahmatullah. Welcome all. Talking about understanding ostomies and colostomy and ileostomy types. And really, it's our pleasure. Is there any question or? Okay. So here we are. Now, we're starting now talking in the colostomies, and now we are going to discover the types of colostomies and how we will be able to deal with these aspects. Now, the name of this device or procedure is determined by the places where it's already going out, where is the connection of this stoma, and from that it takes the name. So either we have colostomy, which is by the name, it's come part within the colon part, or ileostomy, which has come from the small intestine, or ileostomy part. In general, we are talking about this stoma, which is open, that determine the place of the abdominal wall through which part of the bowel is brought to the surface to allow the stool passage. So it's so simple in this definition to know exactly about what we are talking about. Here we are describing this stoma location. The main differences between these two types, it depends on the place of this open and the impact of that on the either the complications or what are the patient needs, and of course the characteristic of effluent that will come out. So the material or the products that will come from this stoma, it be characterized by either colostomy or stoma. It depends on where it's already going out from this stoma or this condition. So in general here, we revise the anatomy of stoma. So we know that this is the ascending. It's here to make it clear for us. We're talking about here the ascending colostomy. So it's come from the ascending part of the large intestine. This is the colonostomy. And this is the descending sigmoid colostomies, which can be variant within the descending part of the stoma. Colostomy involves bringing part of the large intestine. So there are a kind of tissues within the colon that will be above the skin level. So it will pass or bring the effluent to be outside to the surface of the abdomen. And usually, it depends on the condition, the needs, the indication located on the lower left side of the abdomen. And of course, the characteristic of the material that will come out, either for the colostomies, mostly will be much more solid or semi-solid and contain gases, because this is the function or where already the responsibilities of the colon in the digestion of the food. Also, this can be also characteristic that the condition or the physiological function of the colon, it's water absorption. So in this case, we are coming to the near the end stage of the digestion process. And this is also important to know what are the nature of end product that will come from the colostomy. When we're talking about the colostomy, there are three categories important for us to know and be familiar with: end colostomy, loop colostomy, and double pearl colostomy. So these are the three types that related to the colostomy as we will come. Let's start by the end colostomy, end of the colostomy. In the end of the colostomy, the distal end of the colon is completely resected or stapled off. Now we will describe or differentiate between these two types by the Hartmann procedure. The proximal cut end of the colon is brought through the abdominal wall to form a single stoma. So in the end colostomy, this is the last part related to the colostomy. There is no functioning part if it's suitable to say that after this open. And this part or this condition that make the colostomies can be either temporal or permanent. It depends on the indication of making the colostomy. Here, these are the three types of the colostomy. This is the end part. So in this case, we know that this is the last things within the colon. There is nothing else. If it's already there in the Hartmann procedure, it will be closed down. This is the examples of the loop where we already have the two opening and end loop, while we have open and semi-open for the colon, as we will come to discuss. Let's come back to the end colostomy. This is the first type, often performed to divert fecal stream and allow distal anastomies, which is part from the surgical connection. Now we will describe here the anastomies. And usually here we should know the indication of making the end colostomies, which is the segment to heal. Examples that include Hartmann procedure. And I think that this is important for us as a colostomist to know this procedure. And the acute diverticulitis and proactive colostomy after low rectal anastomies. Here, let's differentiate between these two forms. First, we start by the Hartmann procedure. This is a way of making the surgery. It's named by the doctor or the first doctor who developed or performed this procedure. And the first time it was in 1921 by Henry Albert Hartmann, French surgeon. And he developed this procedure as an alternative for existing more high-risk surgeries for certain colorectal conditions, aiming to reduce the mortality and the complications. What did he do in this? This is the picture of the Dr. Hartmann. And what did he do? The surgical operation on the colon, specifically for the lower part of the large bowel. So what did he suggest? Often that the sigmoids, in sometimes, they only remove what they should remove. They did not remove all the parts after the stoma. In this condition, here we can see the resections is disease segments. The surgeon removed the affected portion of the colon only. And for the other parts, this is like the colon, there are some problems happen in this point. And they open the stoma. But the other parts within the colon, the doctors, he keep it and he just close it from the up to the end. And in this case, he reduced the amount of tissues that be removed, and he reduced the amount of leakage for the fluids and connective tissue in this place, in the abdomen. And at the same time, it's give the chance for the body that if this organ, even if it's not functioning, stay there, it's still alive. So it's protect the way or the need to open large surgical incisions. This one, of course, in these examples, he need to close this part. In this part, in this condition, they do to distal stump, they call it closure of the distal stump, and the remaining end of the rectum, and the portion of the bowel that leads to the anus. That's why in some condition, because this is routinely now performed in our region, in Jordan, and in other Middle East countries, that the patients will come to say that he feels like he had a stool from the anus. And this is normal to have, and this condition is already barred from the Hartmann procedure, creating what known as rectal stump or Hartmann pouch, and this is part is left inside the body and no longer connected to the flow of the stool. For the formation of the end colostomy, the healthy proximal upper end with the remaining colon is brought outer through new opening, creating in the abdominal wall, typically in the left side. And this left side, this is what we know or most known as the colostomy. When they use usually the term of colostomy and stay alone, they refer it to the end colostomy and they refer it to Hartmann procedure. The characteristic of a stool in this case will go out from the stoma to the back, that's what we know it as a colostomy bag. So this is in simple how it looks like. This is how the condition or the surgeries of Hartmann, he keep this part, he did not remove this part, and from this open, they create the stoma, and he closed this part permanently. In this case, he reduced the space on the abdomen, so he reduced the cases that we need to build the connective tissue or any other complications that will end by accumulation of the fluid in this empty space in the patient's abdomen. The other term that we should know about it is diverticulitis. Diverticulitis is a part or indication for colostomies. It's well known in the Western countries. And here, to understand this condition of diverticulitis, we should understand a little bit about diverticulosis. What is the diverticulosis? Within the large intestine, for some different conditions, there will be a polyp start to appear in the wall of the small intestine and leading to make an opening. So there will be a space for the digestive content to be accumulated in this diverticulitis in these cases, as you can see. For some condition, this will be accumulated here for a long time, which will be lead for inflammation. And this will lead for inflammation that can affect all the colostomies, all the colon, which will lead at the end, as apart from the conditions for making colostomies. So usually in this case, they cannot keep any other type rather than end colostomy. So they will open and they will bring out a type or part from the colon and keep it out. This is how it looks like, the diverticulitis. You can see this is in the wall of the large intestine. And when the food or the digestive components come inside, start to be accumulated, which will make an inflammation, and in this part it will lead to dysfunction of the colon and stop all the procedure or all the function of colon to reserve the digestive function. This is also another maybe more clear for how it looks like. So this condition here. Anyway, there are so many suggestions about why this developed in this case, but there is no assurance about specific reasons. But this is also life-threatening issues, especially when it's come to develop the diverticulitis or the inflammation happening there related to the infection. It's well known in the Western population more than in our region, but still it's can happening. Usually it's affected. Usually it's affected the it's affected more comparing to the. It is the diverticula, which is the diverticulum. This is the opening or the room or chamber that we see it from the wall of the colon. And this is similar to herniation when it's happening in the wall of the colostomy and leading to accumulation of the food there. And this is typically can be ranged either from a few milliliters to centimeter in size. And there are, at the beginning, there's less symptoms until it's happened to be complicated issues, and this need the surgery to remove this infection outside. The most common location usually for diverticula is sigmoid colon and the S-shaped part for the large intestine, and usually it happens at near the end of the digestive system, so it will be much more close to the anus, and that's why it will end by end colostomy type. When this has happened, or infection, as we say, that it can lead to life-threatening issues, and it can lead to severe complications if it is not taken in consideration, because it will lead at the end to the colon obstruction and lead for a bigger problem. The third concept that we discuss about it, it's a rectal anastomies, and it's important here to know this procedure. Anastomies, usually, it's when they make two openings to come inside each other, and in this case, they will keep the flow of the items to come from this part to another part. So the anastomies in general, they will put two hollow organs inside each other and connect it to the end of the bone. Usually here they would like to connect kind or part from the large intestine to another kind or part from the large intestine. In this case, until they will make allowance for this one to heal, they will be in need to have colostomy from the other side to make sure that this connection will take time until the healing happens and it will not be affected by the bacteria and the gastric solutions. So this can give us here how the anastomies will happen. So this is there will be something here and they cut, and there are different techniques surgical. Anyway, this is more among the gastrointestinal surgeons that will work on this kind. So either it will be complete to the end, either to be in a side to side or side to end or side to side. Now, until they will give a chance for this to happen, either they will make the flow of stool to be outside, so this is end colostomy, or they will make the open from the other far location, so they will give it a chance for this wounds to heal. The well-known procedure within the world of the colostomy called the low rectal anastomies, which specifically refer to the surgical connection made in the distal lower of end of the colostomy, is joined to the remaining portion of the rectum, or in very low cases directly to the anus. After segments of the bowel, usually apart from the rectum or distal sigmoid colon, has been removed to eliminate or to make sure that the problem in that place already executed or excreted out. So the other issues here to think about is the term low, which is indicate this connection when it's made very close to the anal canal. So we are talking about the last part of the large intestine, often just a few centimeters above the anal verge. And this is approximately the pelvic floor muscles and the anal sphincter, which is technically a challenging procedure and it's not easy surgery to be done. Now we can see, or in the other slides, we will see how this procedure performs. The other also indication for the end colostomy, it's the rectal cancer, and this is the most common reason, and it can be lead for anastomies and end by end colostomy type. This is most common reasons if the rectal tumor is located in the end or lower rectum and the affected segments along with the surrounding lymph nodes, so they will need to remove it, and end by complete resection. And this is procedure, usually they call it to end the end colostomy in this way, low anterior resection procedures, or LAR. So this is the kind or type of surgical procedure that will be end by end colostomy, and also it may or may not use the anastomies for this one. The other indication also for end colostomy, it's IBD or inflammatory bowel disease. I'm sure because this is abundant disease and the prevalence of the disease is very high, and it's in selected cases also Crohn's disease or ulcerative colitis, which is also in need in some kind of care to do the anastomies and also to end by end colostomy, either permanent or for either permanent end colostomy or temporal end colostomy. We have also a complex diverticular disease that we discussed about Hartmann procedure, and they would like to exactly determine the diverticular part and then remove it. In some cases, the diverticulitis, when it's happen in specific sigmoids or specific segments within the colon. So simply they will cut and they will make the connection of the colon, and at the end they will end by anastomosis, and also open the end colostomy for time or temporal time until the healing happens. But in some cases, the diverticular places, it's already distributed among large areas. So to save the colon, the doctors start to think that only they can cut small pieces. So they will end by more than one part of the colon, and they need to make more than one anastomosis or connection to make this performed or to make the procedure. Also, the rectal prolapse in some surgical approaches, when they have the rectal prolapse, so they will make this procedures to make out the rectal up and make the anastomosis part within that to pull out the rectum sphincter. And this is technical procedure. This can be done now by laparoscopy or keyhole surgery, or it can be done on the traditional ways of performance. Anyway, each one has its own ways and technique, and of course, it needs a specific taking consideration issues and parts to be done in a proper way. Now, there are the robot-assisted surgeries for this anastomosis to build it. Now we will know why this is still complex, because in the open procedure, it's not easy under the stress of the surgical or surgery room or surgical theaters to be done in the proper way. Now, in all this, the key steps regarding to the end colostomy, we should take it in consideration, and with the related procedures, it's a mobilization of the colon and rectum. So when they already make this connection of anastomosis and making the end colostomy, they should give a space for the colon for movement within the abdominal wall, within the abdominal cavity, and this because the functionality of the colon, it needs some elasticity in the movement. And there are the TME, or the total mesorectal excisions, how much the space that already removed from the rectum, because this will affect on the quality of life of the patient. And when we come to the nutritional facts, I think it will be with Ms. Jennifer. So in that case, we will discuss more about the better way or the best option for making this movement or the procedures and the kind of nutritional deficiencies that will happen for the transection of the rectum, of course, the techniques of the opening this or creating the anastomosis creation, tension-free for this, because then this is muscles, the nature of the blood supply, integrity check, or ear leg test, and this is surgical concern to make sure there is no leakage will going out, diverticular stoma, and of course, they will need to protect this part, as we said, either by colostomy or ileostomy. What's important that to keep it away from any irritations. Here in details, so what are the indications that we will take it in consideration? Because we will end by, or something can lead us to end by end colostomy. And during this procedural anastomosis, we should make sure that the stoma opening itself within the surgical procedure and the connection or the weight of the procedure assure that the mobilization of the colon and rectum stay to be in a ways allow the tension-free environment. So we will not have the tension that will lead to the anastomosis to be reopened or detached from each other or inflamed. On the same time, the nature of the colon already gets the parts from the movement. In this case, we should ensure that the colon gets the space for free movement within these limits that already, or something that should be taken into consideration. And this will not affect the other organs within the abdomen. So this is how they make the or think about the procedure. For the total mesorectal excisions, or TME, which is also part from the surgery itself, which involve meticulous dissection around the rectum within the specific anatomical plan to remove the tumor along with its surrounding fatty tissue and lymph node, and this is to minimize the local recurrence. So they will end by what they call the safe zone during the surgery. So they will remove the, for example, in the cancer, they will remove the part from the colon and they will remove also another kinds around it. So in this case, especially when it's common rectal cancer, they will affect the voluntary sphincters. So as a solution, they need to make stoma for the patient, and this can affect the end of or the way that the patient will live his life. On the same time, the nature of effluent that will come by after the rectal cancer surgery, it will be different than the colostomy or end of the colostomy that come from a different procedures or different ways. In some cases, they will be able to do only anastomosis and keep the endostomy or the end colostomy for temporal reasons or temporal time until the healing happens. And it depends on how much the tissues that they need to be removed or get it out. Transection of the rectum, and it's transected or cut at the point to consider oncological safe, as we say, for the cancer or below the disease segment. And this cut is often made very low at the pelvic, close to the anal sphincter, so it depends on how they will end by. So now for the anastomosis creation, there are different techniques. Also, this is surgical concern more, but it's important for us as a people working in stoma to know these details within the surgery, how it's already done in the surgical room. And this will give us insights how we will expect the complication that to happen. The first technique in the creation of anastomosis, they call it stapled anastomosis. This is well-known technique, and this is most common methods for a low rectal anastomosis, specialized in the circular stapler. احنا عندنا زمان يعني اللي كان يكون في تذكر لما كنا نربط البربشين مع بعض نلي المي نحط في جوا تقريبا شيء بشكل هذا الستابل anastomosis. We will see it in the clip, so I don't want you to no, I want you to go to the how we will make the anastomosis. I will send for you the I think there will be in a video, so maybe it's not uploaded here, but I will send it for you how it's already end by or done within this condition to make it clear for us how this make or how they may do it in the surgical and during the surgery. So it will help us here to understand the creation and how this connection can be done. And it will tell us about the complication that's expected for the patient. Another technique, and they call it hand-swing anastomosis, which is less common for very low anastomosis, and it's not easy procedure, and it will end by side-to-side anastomosis in this way. We discuss about the tension-free of anastomosis, blood supply. It's important because even this function or this part from the colon will not receive any food or any digestive content, but also should be well supplied by the blood because this points need to be healed again. So this is the important condition about it. And in this case, the patient, if they end by the Hartmann, he will complain of stool with the blood or some comments or blood come from the anus. So this is normal to have it in this way. Another important part here, we would like to make the end colostomies get out, and there is no any content of the food that will come to the anastomosis part inside the abdomen. And they make here what they call it ear leg test. So they will perform a check for any leaks, and this by pull the air inside this place and make sure that the anus into the rectum pelvic will filled with the saline. Bubbles indicate the leaks, which need another suture to make sure there is no any content from the GI will go for this anastomosis, and this will make sure that the end colostomy it's already in the content outside without making any part inside it in this way. Right, now for us, what we should take it in consideration in this case. There are a lot of complications can happen with the patient during this time, either because here mainly we're talking about permanent, about temporal end colostomy. In the temporal end colostomy, the patient will stay also in a close contact with the healthcare team, comparing to the temporal part with the end colostomy. In this case, it's important here to make sure that the stoma it's in a part from protecting the anastomosis. It's not to be permanent for the patient. And in this way, the doctors here will arrange that they will do another surgery. So there will be some complications can happen, either for the poor blood supply in the anastomosis or in the colostomy itself, and the expectation of infection. At the same time, there will be a prolapse or over protruded colostomy. This is all repeated or frequent complications that can be happen, and it's important for us to give this concern, because this condition can stay with the patient for 3 to 4 months, and in some cases 5 months, until they will make sure the anastomosis inside getting healed, and they will close the colostomies and make the functionalities of the GI to go in the proper ways. There are several complications can happen in this case, either for anastomotic leak, closing can happen, or from the inflammation. There will be strictures. The opening in the anastomosis will be very small, so it will end by closing again. So this is condition. Within this long time of infunctionality, there will be an LARS to happen, or low anterior resection syndrome, which is at the end characteristic or type of the bowel dysfunction, infection, as we say, bleeding, or la samahullah, nerve damage. So this is all, we still in the first type. I don't want you to lose. We're talking about the types of colostomy. So we start with end colostomy, and now we describe why they end by or why they need the end colostomy and what are the indication. And we talk about Hartmann procedure, diverticulitis, and anastomosis or anastomosis. And in each one, it either can be permanent or temporary. Okay, so in the end colostomies, it can be done in both cases. In general, if it's end by permanent end colostomy, so that's it. All the other parts within the colon and the digestive system will not be in a function anymore. Okay, so they will end by lifelong procedure for the patient. In this case, if the end colostomy were permanent, which is usually it will come in the sigmoid or descending colon, typically on the left iliac fossa, and the transverse end colostomy can also be created in the upper abdomen. It depends on why or the indication of having that case. In both cases, either it will be in the sigmoid or it will be end by the sigmoid or descending colon. If it's end colostomy, so it will be an end colostomy. That means similar complications, similar considerations, similar parts. The only issues that we stop about it and we make clarification about it, it's either this will be permanent or temporal end colostomy. So I hope this is clear. Is there any question about the end colostomy? So this is the most, let's say, known. This is the most, a lot of our patients already come as they are end colostomy. So before we go, I think we have here, okay. Thank you, Arwan. Here we have the loop colostomy. What is the loop colostomy? We are talking about loop of the colon, usually transverse or sigmoids, brought through the abdominal wall. An incision is made in the exposed loop, creating two openings. So when we see this stoma, there will be two openings that are joined at the bases. So the cut itself, it will not be for the all kind. There will be still connection between them. And the proximal active lymph through which stool exists, and the distal inactive or mucous fistula lymph. So we will have two openings, one that will produce stoma, the other to produce stool or effluent. The second one will not produce the effluent or any stool or any solution. We call it here inactive or mucous fistula. That lead bypass to the colon to the rectum. A plastic root or a bridge is often placed under the loop to prevent retraction in the immediate postoperative period. Now, one of the most repeated complications that can happen, which is the retraction. What is retraction? That means the open itself, it's coming to do go down. And this is something expected in many cases because the colon already is moving. So the body itself will try to get this part that we take it out to be inside. That's why during the procedure, the doctors have to fix this part outside. There will be some ways to make sure that the retraction will not happen. And usually this is happen at the beginning time. Mostly, the loop colostomy, it will be a temporal procedure. So it will not end by lifelong procedure. Okay? Indication for making the loop colostomy.
سوري بس اللوب كولوستومي انا ستيل صراحه مش كونفيوزد فيها شوي انه الاوبننج انه واحده بتكون فور فيسز والثانيه بتكون فور ميوكس
يعني هي and we call it a mucus. Usually it's come with the solutions. Here I will come back for the photo so you can see the first photo that it will clarify for you. Sorry, this is. So this is the loop. Here the loop. Okay, so we finished the end colostomy. Now the loop. The stool will come from this one. This one is still it's open, and it will get some solutions from it, but will not have any stool coming from this side. We will have only stool come from this side, and the way that the procedure will be done should make sure that even if the stool come from this side, it will end by going out. Now, usually this procedure, it's not all, it depends on the case. This will be in a temporal kind of the colostomy. Is it clear now?
Yep, shukran.
Okay. So now let's start here. We talk about the type of the end colostomy, and now we are talking about loop. Loop from its name that we are talking about loop opening. So there are two type or two openings that come outside, and this when we have the stoma, we have this two opening, open and open. One will come with a stool, so this will be connected to the beginning of the GI, and this one connected to the end of the GI, and the stool will come from one. And usually this, of course, there are a lot of indications, as we will see now, why it's already happened. In many cases, you will see here in a plastic piece or some other kind of medical equipment or some procedure come with the patient from the OR. Usually it will be in a plastic rod or bridge that will open to make sure that this both will not slip down or going down after the procedure. Now, why we will have this one? So why this condition or complicated conditions again? One of the main reasons for having this one is the anastomosis. So there are some surgical procedures done end by anastomosis. So there are a kind after the loop surgery. So this is the stoma, this is the loop here. Within the following part from the stoma, there are anastomosis procedure done. So there are two pieces of the intestine getting connected to each other. So we would like to give this type of time to be healed, and we don't want the solutions to come inside and make any inflammation. On the same time, they don't want to make another anastomosis. So what's the difference between anastomosis procedures when it's done on the colostomy and when it's done on the end colostomy? In the end colostomy, this is the intestine, so we end by the stoma to be here, and then we make the procedure. Now, when they finish in the temporal sides, they need again, here we have a wound or kind of anastomosis that's done in the intestine. When they ended by the end colostomy, they should take this part and again make another anastomosis. While in the lobostomies, they will only fix these two parts together, which is usually not fully separated. And that means the healing of the loop colostomy will be much easy to be healed. So it will allow much more time for the patient to getting well and improve the quality of life after the loop colostomy comparing to temporal end colostomy. And again, it depends on the patient condition in general. So it's not fixing rather than this is the researches or the studies, how they already classify the types and the complications of. And in the loop colostomy, there are also kind of complications which is different than the end of the colostomy regarding to, as we say, the retraction of the stoma, or also the possibilities that stool will come from the second of the opening to pass through the surgeries, which can be done and can happen, and this is not need also monitoring and focus from the patient and healthcare. Where the location of the loop colostomy, usually it's come in the upper abdomen of the transverse loop colostomies or the lower abdomen of the sigmoid loop colostomies. It's more common to be in the upper abdomen comparing to the end colostomy, which would be in the lower abdomen. And this can be done in the following, or the third type, we have double pleural colostomies, and this is less common, but also it's involved complete division of the colon with the both proximal and distal ends out of the separate stomas. It's similar, double pleural colostomy, to the loop, but the two openings are much close to each other, and the mucous fistula, or that one, the inactive stoma, will be smaller. So they already make it smaller, and they defunctionalize it by either tap it or make semi-suture on it. But you can see it when you open the pleural duct. Anyway, this is the, I hope that this photo will be clear for you. So this is pleural, so this is the stoma, the opening, and this is, you can see here, that we call the mucous fistula, and it's much smaller and less active and much close to the stool opening part. This is also this photo for the loop colostomy. So you can see here there are the active part and the inactive part. So in this case, in the blue part, this is the we call it power mucosa or mucosal fistula. So this is inactive. So this open for the inactive, and this is the active part of, and this what we will see the stool or filium come from it in the loop colostomy. Here, I hope you can also notice that there is no complete separation. So that's why the closing of the stoma later will be much proper for the patient. The same like the loop colostomy, the double pleural colostomies, it's usually temporal, in many cases temporal. Usually this opens for emergency situations, trauma, or severe inflammation, and when there are a need for follow-up. That's why they do it double pleural. Because during the surgeries, the doctor, during the emergency situation, maybe the same surgeon are not sure if they already end all of the problems or something extra needed. So in this case, they will prefer to make the double pleural colostomies and keep following up the inflammation if it's there, the bleeding if it's there, and so on. And that's why they kept in this case. Anyway, in general, either there are shared indications for all these three types even within the specifications of each type alone, but there are some shared, and usually it will start by the colorectal cancer, as you know. And colorectal cancer now one of the highest prevalence cancer among the male group in Jordan and in many around countries. We are talking about one of the fourth leading disease among the international population. So the prevalence of this condition is getting to be higher more and more, and this will lead at the end for some part or kind of the treatment by stoma, and at the end there will be mainly or leading by permanent diversion after the abdominal permeable resections or APR, which end by removing a large part of the colon, so they will end by colostomy. Again, mostly can be by end colostomy, but this is not only the case. And we talk about the diverticulitis, and we talk about inflammatory bowel disease, and we also we know about the bowel obstruction, which end by different reasons that end by infunctionality of the colon, so it will end by one type of these colostomies, either for permanent or temporal reasons. The fistula, or the abdominal fistula that can be happen, which already lead to protruding or getting out of the stool in the abdominal wall and end by infection, perineal wounds, so it will end by wound healing. We have a recommendation now within the pressure ulcer treatment guidelines, and it's a recommendation, it's not mandatory, but this is an example for the sacral fourth stage pressure ulcer to have the colostomy, to have end colostomy, and they assume that in this case they will give more chance for the wounds to heal and better quality of life for the patient in comparing to keep the patient in incontinence, mainly for the stool continence and its complication. Also, apart from the colostomy or the colostomy procedure, the congenital anomalies, and we discussed that in the congenital anomalies, this is the reason when they already create the first colostomy surgery, as we take in the history module, that why they suggest what they call it the fake or manufactured anus, or which what we know now as a stone. There are important techniques, and I know that we are not surgeons, but maybe you get a chance to come as assistant the surgeon in the procedure during the colostomy creation. Now it's worth it to say that there are subspecialties start now to appear within the gastro surgeon and the GI surgeries within the GS for colostomy creation. So it starts now to be much more specific with the development technologies advances. The robot surgeries or robot assistant surgeries start to make or create this stoma to, of course, end by proper resin. Usually, this is historically done by the open surgery, so just they will open the abdomen, and this is what they call traditional ways. And then after, in the following period, they start with laparoscopy or robot assistant surgery, and there are several types of doing the procedure. Now, from our side here, it's important to know about the site selection. So, when or where the stoma will end. This is important because this is apart from our job description or our scope sense. What are the factors that we will think about it? Now, first, it's important to know the indication. So, are we talking about permanent or temporary? Why this patient will end by the stoma? This is important to know. And of course, in the emergency, maybe you don't have this luxury, but in many procedures, when this is planned, so we should check for the patient comfort and safety. This topic will have a lot of guidelines now talking about it, and we will come in it for details. So if you did not catch all the points now, it's fine. Just take this as an idea for you as an expert in colostomy support patients. We're talking about two concepts: patient comfort and self-care. What is the most suitable for the patient that will end by the stoma place? This will take in consideration either the dominant hand of the patient, and it will take in consideration the abdominal circumferences or the abdominal size, and also the routine movement of the patients. For example, for us, Salah, when he already will go to pray or not, and the ability to do the self-care. So this is all conditions that will end by the site marking, when already this will take in consideration that if the patient, for example, wear thobe or abaya or jdash or kandura, or will end by t-shirt and pants. So this also will be apart from our condition. Now, at the end, let's say that the stoma nurse will end by marked side. So from this marked side, the doctor will start the incision. And now, with the robot surgery and the laparoscope, they will enter the body from this side to search exactly where are the conditions that they will work to make the dissection for it. In this case, or the opening, the abdominal wall dissections that they will come in and they will make sure that they will not end by any unnecessarily removal of the body part. So that's why they appreciate what Hartman, for example, even with the temporal for permanent endoscopy, they appreciate that keeping or bringing some part of the tissue, so we will prevent the connective tissues from development, abdominal adhesions, and so on and so forth. So this is the techniques that start to end by. And also, for this surgery insides, what they are doing in the surgeries, they are cutting or injury in the abdominal wall, which include the abdominal muscles. So as apart from the complication that can be happen, what they call it parastomal hernia, for example. And this is also important to be considered. What is the parastomal hernia? That will end by part from the abdominal organs, intestine, to pull out in the abdominal wall, which make a pressure on the sides of the stomach, pain, and also it can be complicated the digestive flow because there is injury happening in the abdominal wall. So the techniques of opening the abdominal wall, its effect, and also the assessment of the abdomen. So at the end, the doctors and the nurse and the patient, they will make decision not only to check for what the patient prefer, but also the most suitable ways of making the dissection of the stoma to not affect the abdominal muscular wall and end by hernia, which can be lead to, in some cases, for reopen again and make a different procedures just only to solve or support the hernia removal, especially when complications can be happen from the herniation before the stoma. So there are also different types of the herniation when it's happened in this condition. Also, the power localization at the end, there will be because when the colostomy will coming out, there will be a connection or traction for this stoma in the abdominal wall. So they will make sure the power localization is kept on. So they will give a space for the colon to keep moving. At the end, this will not make any pressure on the blood or the nerve supply and the blood supply. There are also important here to know about the stoma maturation, which is what will happen within the stoma itself within the time. There will be something that after the stoma itself, the stoma will not stay on the same condition during the day. There will be some changes will happen. At the first time, especially for the colostomy, we will notice there will be a protrusion. The stoma is bigger or big comparing to the stoma that we need. Why? At the end, this is surgical procedure. Surgical procedure in the fresh day of making the stoma, it means inflammation. Inflammation, as you know in the wound care, there will be edematous part. But within the time, this protruding start to reduce the amount because of the inflammation condition start to get reduce the condition of inflammation. So it will end by this protrusion and this enlargement of the stoma to get smaller. So this is what already they take it in consideration in all cases. But in the endostomia, it will be much clearer. In the loop colostomy, because of the open itself, it will be from the upper sides of the colostomy, and it will be on the longitudinal, comparing to the endostomy that will be cut in this way. And that, because it will be end by the two lumens, the edge inside the colon are structured to the skin edge, creating double parallel appearance. And the stoma root or bridge is often placed in behind the loop to prevent retraction. And this can affect the skin near to the stoma. So this is because we are talking about here hot solutions that will come on the skin. The temperature of the skin 30, 34, 33, but the solution that come from inside, so I'm talking about 37 with a lot of enzymes. So this also can lead for additional inflammation around the loop stoma, not inside the colon in the loop stoma, but around the skin around. At the end, the procedure will be that they will close all the parts around the stoma. So this will be, let's say, wounds, and this wounds also can get the complication of the surgical site infection and so on. Now, in summary, so before we go for ileostomy, in general, what are the key messages that we should talk about it? We talk about colostomy. There are 3 types. We have end colostomy, and this is the most known, let's say, about it. Usually, the people when talk about colostomy, they end colostomy, or they means the end colostomy. And we have the loop, and we have a double pearl. Double pearl. This is not well known, or it can be it's only one specific type of the loop colostomy. The end colostomy, which means that the colon it's end up and that's it. So the stool will get out, and either we already worked inside for a temporal or permanent procedure. So then they decide if they would like to reconnect or not. It depends on the patient condition. The loop itself, we are seeing within the stoma, we're seeing 2 openings, and these 2 openings connected to each other in the bridge. And under this bridge, there's something inside here. Usually, it's a plastic to make sure protection for the skin and make sure there will not be a retraction or inserting down the stoma or any skin or epidermis that can cover this area and end by closing all the stoma. The indication for this one, it's the end colostomy. This is the major, can be temporal or permanent, but majorities or most of the loop colostomy, it will be in a temporal reason, and it depends on the conditions about the anastomosis that we discussed about it. So important to know the anastomosis, how it's already done, and what are the expected complications for this one. So we go now for ileostomy. So what is the main difference between colostomy and ileostomy? It's where or which part of the GI that's getting out. So are we talking about large intestine? So we're talking about colostomy. If we're talking about small intestine, so are we talking about ileostomy? The stoma almost always located on the right iliac fossa. Majorities of the time, it's come in a specific location because the difference in the large intestine, it's getting more space, and it's come from the abdomen outer side from the right to the left. But the small intestine, even if it's large, but it's concentrated in the middle of that. So this is important here for us to notice. Now, the role of small intestine much complicated comparing to the large intestine in the digestive process or the physiology of the digestion. Small intestine in the digestion, it contains absorption and making digestion. In this case, when the effluent or the solution will come from the ileostomy, it will be much more liquid, meshy. Between quotation, you can say unprocessed food or not processed, well-processed food, because there are still a lot of enzymes in it, and it will be much more nutrients still. The body will not get the chance to absorb it. So this one will affect on 2 kinds here. The first one, the body consumed large amount of enzymes, but they did not get the benefits of these enzymes. And that will lead for nutritional deficiency for the patient, or less than the requirement that the patient should take. On the same time, the surrounding skin of the ileostomy will be affected by this high concentration of enzymes, which can lead to more skin irritating events comparing to the colostomy. So this is important point, how we will provide proper care for the skin around the ileostomy. In the same time, what are the type of ileostomy? End ileostomy, loop ileostomy, and continent ileostomy or Koch pouch. In the same way, when we call it endolustomy, I think now it's more clear for us that the end colostomy, this is the last part, the loop colostomy, then we have condition for both. Let's start by the end colostomy. Distal small intestine is restricted from the colon and the cut end of the ileum is brought out of the abdominal wall. So this is the end of the digestive process. The colon and rectum may be removed or left as we discussed in the blind pouch. It depends also on the condition. But when the ileostomy, so the food will not reach any part of the large intestine. In this case, either the condition of the patient in need to all this part to be removed, so all the large intestine and the rectum and so on, or maybe they will remove only large amount, but the other parts will be unfunctional and they will make the same technique of heart and pouch, so they will close it from inside as we discussed before. Again, the ileostomy can be temporal or permanent, depends on the patient condition. For example, in the permanent, after panprotectomy or removal of colon and rectum, for condition like ulcerative colitis, familiar adenomytis polyps or FAP, certain condition in the Crohn's and inflammatory bowel disease, this all can be ended by permanent end ileostomy. While in the temporal, in the same way, for divert fecal stream, allow healing, anastomosis, as we discussed, ileal pouch, anal anastomosis أو IPAA كلها هذه بتكون صار في عندي عملية anastomosis, so we will give the chance for anastomosis to happen. Or in emergency situation, as we say that when they are not sure that the anastomosis will work fine, so the doctor will end by endolustomy, and the patient will be rescheduled again for another procedure or another surgery for proper anastomosis. It depends on the condition. For the location of the endolustomy, it will be typical in the right iliac fossa, and make sure that the issues that the skin here are weaker than the other kind of the skins if we're talking about this condition of the skin and the nature of effluent that will come from the ileostomy. The loop ileostomy, we're talking about similar to what we discussed in the loop colostomy. Ileum, in this case, instead of colon condition, and the incision done, and we will end by two opening, inactive or mucus posterior will active, that will come the solution outside. And between them, it will be rod or a bridge, usually it's done. Mostly, the loop ileostomy will be temporal, and again, this condition can be used as a protective ileostomy. So in many conditions, especially in the surgery, in the emergencies, because who will be on call, you know? So they create that they will make here much more safe for the doctors that will work in emergency conditions. And then later, the patient will be planned for anastomosis, either G pouch or different kinds of anastomosis will not come in. So this protect the patient and protect the license of the doctor. At the same time, it will give a chance for another or further investigation why this problem happened, if it's intestinal obstruction or trauma or injuries or internal bleeding and so on. Also the same for ileostomy, the location will be much as or in apart from the right iliac fossa. We have a cock pouch or a continent ileostomy. Incontinent ileostomy, again, it's a less common type, مع internal pouch or reserve, created for a section of the ileum within the abdomen. A nipple valve machine is also created from the ileum to prevent continuous leakage. Listoma, in this case, it created to make, created to give the patient or insert catheter inside. In this case, we are not just only stop the flow of GI solutions to the specific area. Rather, we can use it to give the patient something. So in this case, we will be able to give the patient, not only to waiting what the patient will take it outside. Why this can be done? There are several reasons for the continent ileostomy pouch. Either because the patient condition itself go for ulcerative colitis when there are a huge amount of above these parts will be unfunctioned, and we still need to give the patient solutions or nutrients or whatever, and in some cases both. And it will be ended by different conditions, but this is the time that when we end by the catheter going out from the ostomy, and this catheter we can give the patient not only take it out from the patient. So in this case, this will be a method for feeding the patient. In general, the ostomy, again, it depends on the patient condition, maybe due to the inflammatory bowel disease, anastomosis prolapse, colorectal cancer, rectal trauma, protection of distal anastomosis. So they determine that after the ostomy, there are something that they cannot make it or function it, so they will stop the use of it. We heard a lot about the inflammatory bowel disease. I'm going to here to focus about the ulcerative colitis, which is ended by prostatectomy with a permanent and end ileostomy or iliac pouch anastomosis. The ulcerative colitis start now to get increased in the prevalence. There are a lot of studies say that ulcerative colitis will lead to cancer, colon cancer, and it means that there will be a huge permanent irritation on the internal wall of the GI, mainly the large intestine of the colon. So it will end by crushing of the mucous membrane inside the colon. The Crohn's disease, I think anyone work in the field of colostomy, they already hear about the Crohn's disease, mainly to be in a congenital or genetic factors affected. But at the end, it will end by extensive small bowel disease, closure happening or the opening of the GI already in, severe refractory disease that doesn't respond to the medical therapy, and it takes, of course, time to reach to this condition, but it can still also condition that the patient should take it in consideration. We have in adenomyces polyps, or FAP, which is end by, or in some stage of the disease, will end by closure happening on the tract or lumen of the digestive system, so it will end by or need for either colostomy or ileostomy. Depends on where is the concentration or the decision, surgical decision, to which part to be removed or fixing. Again, colorectal cancer, which already now we discussed about it, and it starts to getting more and more problem. Again, rectal trauma or injury, divert fecal contents and allow healing, so can be done also either for permanent or temporary. And in both, even in the last time we discussed the rectal trauma or injury, it can end by colostomy or ileostomy. It's not necessarily, it depends on the, because each patient has its own condition. So it's not necessarily that we will end only by colostomy. Some cases, the trauma, the injury affected all the colon, so they will, with a safe zone, they will prefer to go for ileostomy until the healing or the problem to be solved. Important for us here, we notice the anastomosis. So the patient, when they already come with anastomosis and stoma, so we should have two focus or two eyes on the patient. The first eye for any complication related to the stoma itself, and the second eye, any problem or complication related to anastomosis that's already open. And this can be a kind from the surgical site infection, bleeding, disturbance of the digestive system, or maybe end by necrotic or insufficient blood supply that will come to this. In general, this is techniques for ileostomy creation, the same what we discussed with the colostomy. It can be open, minimally invasive. So now the techniques or the trends in the surgeons that they don't want the open surgery or the open incision or the big wound incision, so they start to rely more on the laparoscopic and robot assisted surgeons. And now conditions start to appear more and more. Now, for the ileostomy, for the site selection, the options are much limited. If we compare the ileostomy to the colostomy, the options are much more limited because at the end we are in the right iliac fossa. So the place in the abdomen are much more limited. Anyway, we would like here to consider the visibility for the patient and the nurse and avoiding the body prominence or skin floats. So this is also additional important and restrictions in the ileostomy comparing to the stoma, which can give us more varieties that to think about it during the location or the place where the patient can prefer. In the ileostomy, still we should check about the condition of the patient, the preference of the patient, but the limited amount that we have it if we compare it between ileostomy and colostomy, because at the end we will end by right iliac fossa, so this is important. Again, now for the abdominal wall dissection, similar to the colostomy and ileostomy dissection, subcutaneous tissue, fascia, muscle. So again, the complication can be happen for the herniation, peritoneum creation, opening, and usually in the ileum will be more circular compared to the colostomy, if you're already familiar with that. And this is important condition. Bowel mobilization. Now, in the small intestine, the frequency of movement higher than large intestine. So in this case, the bowel mobilization or the space that will be left for the patient intestine also should give proper allowance for this one. That's why, for example, in the loop ileostomy, usually it's 15 to 20 centimeter proximal to the iliac valve had replaced. So even in sometimes in the loop ileostomy, you will see the movements. You will be able to watch it by your eyes, because at the end the movement is faster comparing to the large intestine. And this in the loop ileostomy, which will be a temporal, should give the space for the patient. And also in maturation for the ileostomy, the same what we discussed in the spot, we will have the protrusion. Here the protrusion will be higher comparing to the colostomy. So we're talking about 2 to 3 centimeters. In open or the amount of ileum that will be above the skin will be more comparing to the stoma. And after the surgery, because of the inflammation, will be even higher. Here in the textbook that we take from this information about 3 centimeters. In fact, in some cases after the surgery, you will end by 5 centimeters. So you can notice here the ileostomy, but the nature of the open, you will notice the differences are much thin comparing to the large intestine. Crucial also for the ileostomy regarding to the loop ileostomy, it's brought through an opening, so it will be much more longitudinal comparing to the colostomy, so it will be a little bit bigger, and this can affect on the abdominal muscles and wall. So the notice of any changes, important for the surgeon to know these details, because this can make pressure coming from down up to the stoma, to the ileostomy, and it can end by stretching the ileostomy or stretching the ileum, and this is can lead for additional complication when they will close it at the end. Now the closure of the surgery, now there are different procedures, and this is surgeon concern more. Abdominal incisions is closed similar to the stoma. Here, I try here to give you just only an important or small tips to compare now the colostomy with the ileostomy. So from the bowel segment, colostomy, it's come from the large intestine. So this is colon, ileostomy, small intestine. Now the typical location or most frequent location, we are talking here about left iliac fossa, we're talking about right iliac fossa, and this is limited space comparing to the colostomy. The kind of things or stool or effluent that will come from the stoma in the colostomy, it will be solid, semi-solid, and may connect with the gas, while the ileostomy will be liquid, meshy stool, high digestive enzymes, and we concentrate here high digestive enzyme. That means it will be more irritant to the skin. And now there are a lot of things to keep it around the stoma opening, and the reasons when they already start to create these products come from the protection of the skin, mainly for the ileostomy. Now we are using for both, but they start mainly because of the high digestive enzymes, and this is very severe and irritant for the patient. For the odor, of course, here we're talking about much more processed food, so more defect fecal odor, while it's not in the same in the ileostomy, because this is still not unprocessed food in the same way. The stoma appearance can be flush with the skin slightly protruding, typical large diameter. Here we are talking about protruding around 2 to 3 centimeters to protect the skin, and also the nature of the smaller diameter or thin comparing to the colostomy. Skin irritation, now the study said, as a colostomy nurse, we should think in both cases in skin irritation, but in general, based on the frequency or the prevalence of the studies, it will be less than ileostomy. And here, I would like to focus on that. Less than, that doesn't mean it's not there, but it's just only less than because of the digestive enzyme. In fluid electrolyte balance, the patients here we need only to increase the amount of water or fluids. But for the other nutrients fact, it's fine, rather than in the ileostomy, higher risk for dehydration because the patient did not absorb all the amount, electrolyte imbalance and water absorption and higher output. So in this case, the patient had a special program or special ways to check in the nutritional part. Now for the pouching system, now in general, both can be done on the same on the pouching system in bags or base, but in the ileostomy, we need to be more careful, more skeptical, especially because we'd like to serve or survive or protect the skin. So this is what we important to say. Now, which type of ileostomy you will use? If you have two types of system, pouching system, so use the best for ileostomy because the skin there much more irritant. Now, as we said, they create this barrier cream to protect, or the starting in creating ileostomy, but now they start to recommend it for all. And we take about indication for both. Anyway, the indication is much more medical decision comparing to caring. This important to concentrate on how we will assess or evaluate the patient after. Now, the post-operative care and living with stoma, either for permanent or for temporary, if it's for the end of the life of the patient, or for short time, and then there is interruption happening to the quality of life. And in both cases, the trauma that will have it for the patient will be in a post-operative period, mainly days until 1 month, 40 days after the surgery. So in this case, the patient will be much more close to the healthcare providers. And we, as healthcare providers, and the patient family should be sure about stoma assessment and informing the changes that will happen. And to which extent we are accepted changes comparing to not unacceptable changes. Regular monitoring of the stoma viability, the color, which is supposed to be in a pink to the red, so it's not blue, it's not yellow, it's not black, the size and the output. Important here to make sure that the patient able to use the pouching system, and the pouching system now, there are variations either for 1 piece or 2 pieces. And in both cases, the patient should get the proper instructions before the surgery and after the surgery, how they will deal with the empathy, choose the suitable size for the base, applying the bag, and so on and so forth. So this is important, and also to make sure we are protecting the surrounding skin. So this is important for the issues of the stoma care, to protect the peristomal skin area and the dietary adjustments. And we will have a special lecture about the dietary adjustments because this will lead for a lot of reflections on the quality of life of the patient, mainly for hydration, the gas formation, the social acceptance, and of course, to make sure the patient take the required ambulatory or required nutritional support for that condition. Now, in case of any complication, so what are the requirements? For example, if we have parastomal herniation, prolapse, retraction, stenosis, bleeding, skin issues, so the patient should be learn that he will contact us directly, and we are able to either take the care within our scope, or maybe in many conditions the patient needs for redo the or reopening to solve this complication. Now, apart from the recommendations within the international stoma associations about the psychological support, so the patients should be, at the beginning was meant preferable. Now they start to be, apart from the psychological support, peer groups, so stoma nurse counseling, they can make like one connection between the patients themselves and making these groups and communication between each other, so they're supporting each other and exchanging the experience within their own experience and their own needs in general. But in conclusion, we discuss colostomies and ileostomies. We know that there are 3 types for colostomies, or 3 categories for colostomies, because if we wanted to come in more details, there are a lot of, for the textbooks, the researchers will take you in more details. But here we are able to connect connecting them under 3 categories: 3 for colostomy, 3 for ileostomies, and we know the differences between them, and we know the rules that we should take into consideration while we are talking about. We just come in more brief, with a little details about why we should have this type comparing to this type, who we end by colostomy, end colostomy, loop, and pleural dual colostomies, and at the end we able to classify it as a temporal or permanent. It depends on why the colorectal surgeon already, or the surgeon itself, lead by this one. And the ileostomy, important for us here to differentiate the patient needs in both in colostomies or ileostomies. At the end, thank you very much for being with us, and I hope that today we did not bother you with a lot of details, but we able to take these messages to protect the patient, and that we able to satisfy the patient's needs. الله يعطيكم العافية يا رب. في أحد عنده سؤال أو استفسار؟ Any question or any concern؟ Thank you very much all for being with us, and see you inshallah next week. From this time until the next week, please be safe. This is Dr. Karim Brasi. Assalamu alaikum.
Recording stopped.